Hello everyone, my name is Karl Gaffney. I'm Professor of Rheumatology in Norwich, Clinical Lead for Axial Spondyloarthritis and Clinical Trials Director. In Norwich we look after over 1,200 patients with axial spondyloarthritis, approximately 650 of whom are receiving targeted therapies for the condition. I'm delighted to be partnering with NAS on this momentous project. I've been involved in the design and look forward to working with you all on the implementation of this challenging but hugely exciting and promising project. Too often in clinic, I've witnessed the unacceptable delay to diagnosis that patients experience. This has such a major impact on the lives of so many young people when they're trying to establish their careers and relationships, secure mortgages, and essentially move forwards with their lives. The sense of relief on their faces when they finally acquire a diagnosis is really emotional, and I'm really privileged to work with patients and to support them in this program and in their quest to achieve and acquire a diagnosis and move forward with their lives. We know that the delay to diagnosis is approximately 8 years in the UK, and we all know and agree that this is unacceptable. There are so many reasons for this delay, and these obstacles are challenging, not only for patients, but for us as healthcare professionals. We need the support not only from rheumatologists, from many other specialists working in the field of Axial SpA. That includes physiotherapists, first contact practitioners, chiropractors, osteopaths, and colleagues in secondary care, including ophthalmologists, gastroenterologists, dermatologists, and radiologists, to mention but a few. There are so many challenges in the diagnosis. We all know that back pain is extremely common in society, and it's very difficult to identify the patient who potentially has axial spondyloarthritis. However, we also know that the majority of patients with axial spondyloarthritis present with inflammatory back pain or experience inflammatory back pain during the disease course. Therefore, it's paramount that we have processes in place to recognize inflammatory back pain and channel these patients with suspected axial spondyloarthritis through to rheumatology, where they ultimately should and can acquire the diagnosis. In addition, many patients with axial spondyloarthritis have other symptoms, and other systems are involved in the pattern or the clinical phenotype of the disease. So it's important that we work with our colleagues in ophthalmology, gastroenterology, and dermatology in particular to drive patients through from their services to rheumatology clinics. We also need to work closely with our musculoskeletal radiologists to devise appropriate protocols for imaging acquisition and interpretation, because even in the hands of rheumatologists and radiologists, the definition of a positive MRI scan typical of axial spondyloarthritis can be difficult and challenging. One way of overcoming this is to arrange multidisciplinary team meetings where we can review difficult and challenging cases and support us in our ability to make this diagnosis. I really urge you to lend your support to this program. We at NAS and within the healthcare community working and attempting to deliver best quality care for patients with axial spondyloarthritis really need your support with this project, and we look forward to driving down the unacceptable delay from 8 years to 1 year. Thank you for your attention.